interrupt the conversation, but I just saw Barry's name jump up, so I figure we'll get started on the meeting. So anyone who has to leave, they can leave.
Well,
All right. Did everyone get the minutes from last meeting?
Yes.
All right. Any questions, comments, concerns? Otherwise, we'll move on. Mike, any correspondence since the last meeting?
no, sir,
I think we have to approve the minutes.
Motion, yeah, a motion to approve the minutes. Do we have a second?
Dr. Sheriff, second.
All right. All in favor? Aye. Any opposed? All right, motion to accept the minutes carries. We'll move on. Mike, any correspondence?
No, sir.
I know there's somebody, before we get to the old business, somebody, I think, Peter, you had to chime in early so you can get to another appointment.
Peter Road, New York State Department of Health Data and Informatics. You're on, Peter.
I found my mute button. It's always a good thing with this group, since you guys are in an echo chamber there in Elmira. Now, after
Yeah, the
vital
reception's
signs.
terrible.
Yeah. Yeah, well, the original plan was that I would be in Elmira today, but that's not happening. So Mike decided to have a great deal of snow down there, so we can just all blame Mike for the weather. Can everybody in there hear me okay?
Perfectly.
All right. So we made a documentation standard change announcement several months ago, which required EMS agencies, regardless of whether they're transporting or not, to list in e-disposition.01 and .02 the name of the facility the patient is being transported to, regardless of whether that agency is doing the transporting or not. Part of that, the intent and the design of that is so that the receiving facility can receive all of the charts on that particular patient. So you have a BLSFR, I'll paint the worst picture, BLSFR patient, BLS ambulance, ALS intercept, and helicopter. You have 4 agencies. Trauma program and stroke reporting are looking for first contact patient care documentation. And in our previous system of doing that, that was a challenge to get. Whether the ambulance was bringing a usually wildly incomplete pink copy from the BLSFR, or the helicopter transport was trying to collect everything and bring it with them in the matter of probably a challenging transfer of patient care, especially if Mother Nature is not especially cooperative. So when we changed the definitions in New York State, we also did 2 things. Or we not only did we spread that out, we also qualified how to document that a patient was being transported, and we qualified what the term unit means. A unit is a vehicle. So when e-disposition.12, which is ultimate destination, is mentioned and it's treated transported by this unit, it means that that particular unit is an ambulance. So agencies that do for fire department first response or fire department, ALS first response is not transporting, but they may ride into the hospital with a particular patient. And again, I don't know all the system structures out in the southern tier. So if both the ambulance and the ALS first response were riding in with the patient, you couldn't have the same disposition for both because the unit is the ambulance. So we qualified what that is, and we sent out instructions on how an ALS first response should be documenting the patient care. Now, that changes nothing about what should be up in e-dispositions.01 and 02, and where it should be the facility code as well as the name of the facility. During the peak of the pandemic, when the peak was focused on Westchester, Rockland, New York City, Nassau, and Suffolk counties, back in the beginning of 2020, I received a data request from the upper echelons in the department. Say, could you tell me how many patients you've transported out of XYZ nursing home with influenza-like illness or positive diagnosis of COVID? And I said no. because, and I'll use nursing homes closer to me where I know more of the names. Daughters of Sarah Nursing Home might be listed as DOS, DGTRS, Daughters of Sarah, Sarah spelled wrong, the O, the F, the words may not be there, and they didn't have a specific code. So now we've created, much to the software program designer's chagrin, we have, there are approximately 11,200 destination codes out there that include all hospitals, all nursing homes, a variety of urgent care centers, some alternate care facilities, which may be ET3 destinations, and schools and colleges. Because as it was progressing, and the ages of the patients being immunized was starting to drop and get closer to the schools, we also wanted to monitor the schools. So that was us thinking ahead. So we inserted the schools in there. The next is correctional facilities, and that'll come out in 2022. So we can monitor data flow and patient traffic amongst all those entities. So it also works with where the scene is as well. The second part of that is that we worked with ImageTrend, who provides us with a state EPCR repository. We pay for it. Don't mean to say they give it to us for free, although that'd be novel. We have the EPCR repository through them. They have a program called Elite Viewer. An Elite Viewer is just a mirror image for a defined visual. And what that means is for patients who are delivered to a particular facility, individuals within that facility would have access to be able to see all of the charts related to it. So go back to the earlier example, and I'll only use Elmira Heights because I met with them on my last trip down. Other than that, I had no idea that it was there or what it was called. Elmira Heights sees a patient, they complete their chart in ESO. They put it up there. They list that the patient is going to whatever the name of the hospital is in Elmira. You'll forgive me for not remembering all the hospital names or where they're located. And then the hospital can see, the hospital is able to go out and see all the charts from that particular encounter as part of that. So they'll be able to see the entire continuum of patient care. So in case anybody was curious, the director wanted something out of my fridge, so that's why I was a little distracted there for a second. But I tend to do what he wants, so it works. So they're able to see the entire continuum of care. So if you're looking at an overdose patient, and the fire department gives a dose of naloxone, the ambulance right behind them gives them a dose of naloxone, the ALS intercept gives them a dose of naloxone, the hospital is able to see that that patient received 3-4 milligram doses of naloxone, however it was administered, and then they're able to make a full assessment of how critical this particular patient is or how severe the opioid that was ingested or affecting the respiratory status of the patient actually is. And then they get a more global picture. Instead of the ALS intercept going, well, I never saw the fire department on the scene give one, so how do I know? I can't put that on the chart because I can't definitively say it was done. Now we can focus on the care that we do, provide better care. So some of the facilities in Southern Tier I know are part of other systems. So if a patient is moved from a facility owned by a system out of Rochester, and they need to send all the they need to make the charts available up to Rochester, they're actually able to do that as well. But that comes with a control that we provide. So this system will allow you only to be able to access the charts from within your facility. So say, for example, a patient goes to Elmira Hospital. Again, I'm making up the names because I don't know all the geography down there. And that patient is flown to Buffalo, to ECMC. ECMC will still need those files provided to them by the sending hospital because it's not part of the same system, if that makes sense. We are, Jacob, the young fellow who sits diagonally from me, and I are more than happy to do demos for the hospitals, demonstrations for the hospitals, and to get them set up. In order to sign up, we ask the hospital to assign an administrator, who is authorized to be able to request that someone be added to Elite Viewer. All of the access to Elite Viewer is handled by the central office at the Bureau because that's how the structure of it goes. But we tend to move on those requests fairly quickly so that the facilities have full access to the patient care. But when you're looking, in the past, or what may be current practice, when EPCR vendor A is faxing a 5 or 6 page chart and you lose page 4, because it got stuck to the Chinese food menu that invariably comes to every hospital emergency department in the state of New York, then you're out looking for a chart, and that has the pertinent information of what you're looking for. This puts it all available online. Hospital is able to download a PDF and load it into their electronic health record, at any time, and they can work to bring, the whole system over. If you have a stroke program, a trauma program, a STEMI program, a sepsis program, or other registries that you're involved with that are looking for access to the entire continuum of the care, now you have it all at your fingertips, and you don't need to call agency A or agency B to say, hey, I don't have your chart from trauma patient A. You can go out to the system and look it up. If there's something you can't find, you talk to Executive Director Pirazzolo. He will help the facility, or you can send them to us, and we're happy to go out and look for it, to make sure that it was there. Sometimes if the software program did not assign the correct facility code to a given facility, we'll figure out, we'll work to diagnose the problem, we'll work with the software vendor to get it corrected and the chart resubmitted. But that is Elite Viewer. Are there any questions? I know I talk a lot and very fast, so it's not easy to interrupt me, but I kept watching the chair to see if you wanted to interrupt me.
No.
And thank you for not sharing your cold. So I'll send Mike Pirazzolo some follow-up instructions so that they can be forwarded out to the STREMAC or to the hospitals, and then you can contact us. Eventually, what we'd like to get away from the EMS agencies doing is faxing charts. Because as we said, some of those faxes end up in the netherworld or mixed in with the Chinese food menu. I worked at a hospital for 3.5 years in the ER. I loved getting the menus because I knew what the specials were, but you had to watch for everything else to make sure it didn't get mixed up.
Peter, I do have one question. Say the first encounter with ET3 and everything is somebody being brought from one area to an urgent care, if that's permitted in the area, and then the urgent care decides the patient is at too high of a level of care for their facility. Would the hospital then be able to get the charts from the previous encounter, or would the urgent care be responsible for relaying that information?
If the urgent care, say, and I'll go back to the Elmira Hospital. If
Arnett,
Elmira
that's
Hospital, okay, thank you. I really have no idea. I just hope I never need your services when I travel through. No offense to any of you. If Arnett owns the urgent care, we can make the connections that you'd have access to that. If Arnett does not, the urgent care would need to send the information along with the patient.
Okay, thank you.
No problem.
So Peter, the ask is that the hospital systems embrace this image friendly view.
That's right. It'll improve the relationships that you have with the EMS agencies, and plus, just as a little backstory that I didn't include in this because I'm told I talk too much. Prior to 2021, EMS agencies, especially BLS first response agencies, did not really have an incentive to document electronically. But in 2019, when the updated continuing medical education recertification manual was distributed, it required that in order to maintain your CME program, the EMS agencies had to start documenting electronically. Well, we started this process in January, and some people had a little bit of a fit. Why are we mandating it now? We're pushing them to get it done now, so we're fixing the problems by the end of the year. And this is where we are. We're going to be helping fix problems all through December while we're, also fighting a peaking pandemic again. And so as part of that, now you're going to get the BLS first response. We eliminated our outside vendor, FedCap, out of New York City, and Mike used to send them paper PCRs every month as requested. We eliminated that vendor. We saved ourselves a great deal of money. We also opened up the paper PCR portal. So the paper PCR portal is much like is just a place where EMS agencies can enter it. They still have to enter the patient's definitive destination. So if Elmira Heights, again, I'm only using a department whose name I know, treats a patient, they were documenting on a paper PCR, they would have to go back to their computer, enter approximately 28 to 30 fields on the paper PCR portal, and then attach the chart, and it would still make it to the hospital now. But instead of it taking 18 months to get there, which was the past practice, now it's there within 4 hours. New York State Department of Health Policy 2104 requires that patient care reporting be completed within 4 hours of the completion of the incident, 90% of the time, because it's all about the continuity of patient care. But this way, all the care is documented electronically. If you're looking at a specific case, there have been a variety of specific cases over the course of time, of course. And then if you're looking at a specific case and you want to look at the global aspect of the entire incident, you're not just seeing the ambulance chart, you're not just seeing the paramedic chart, you're seeing the whole incident from beginning to end. And a doctor who's reviewing a case or a QA program, a quality assurance program, is looking at something, they have the global view and not just a tunnel. Yes, ma'am.
I'm internal medicine in Corning. We're with the Guthrie and we're on Epic. So for example, in Epic, so where does this flow into the chart?
Yeah, I can't tell you how it would flow in with Epic. I could tell you it's an online portal, but you can pull down the PCR. And my very limited ancient knowledge of Epic, because the second hospital I worked at did use Epic for a while. They don't anymore. They were able to put PDFs in along with some descriptors for it, but I wouldn't want to tell you how it would work. But I'd be happy to talk to someone from OHIM at your program to be able to talk them through the process, of how this works and how they would obtain a chart.
It would have to be manually. It'd have to be manually put in under scans for each patient.
Right.
There's no HL7 interface for this.
Correct. But it does give you a PDF of the chart. And the nice part for the hospitals is that this PDF, if all of your charts are coming through Elite Viewer, all of your PDFs will look alike. So they will all be the same format and structure. You won't be seeing, something one way from meds, another one from EMS charts, another one from Zoll. If I hit on the big players in your region, you're not going to look at 3 or 4 different formats. You're going to look at all the same format, and it will make it easier for your medical records staff as well as your program staff to be able to read. Someone has an unhappy young one.
That's my inner child. It's fine.
Is that you actually, Brad?
That is my 7-month-old. He's 2 rooms away with a shut door, and you can still hear him.
Oh, you're in trouble when he's a teenager.
I'm in trouble now, but does anyone have anything else to ask Peter while he's with us? Because I'm sure seems like he has some other stuff to take care of today.
I have 5 appointments at 2 o'clock. No, but I appreciate everybody's time and attention, and it was a pleasure meeting with Dr. Barry and who was that other fine young fellow I met with? Dr. Kellogg, when I came out the week after Vital Signs. It was an awesome discussion, and I look forward to helping bring more of the EPCR program opportunities to the Southern Tier and working with Mike and the STREMAC to be able to make that happen.
Well, thanks, Peter. We won't keep you too much longer for your other meetings. Anyone has anything further, we can get your contact information to him, right?
Right. Mike has all. Oh, trust me, Mike has all of that.
Oh, I've got it too. But
all right.
You take care. Have a good day. Thanks for joining us.
Thank you. Be safe and well, everyone.
Thank you.
All right. We'll touch on a couple of things a little later on about what he was talking about with ET3 and everything. But for now, let's move on to our old business. Brendan, paramedic update.
No real updates. Well, yeah, actually, I'm sorry. I take that back. Every fall I do overlapping classes. But my one class is finished. Everybody passed their practical. So that was 9 people that passed their practical back on November 5th, which is a Friday. Some of them have already taken and passed the National Registry exam, and they're taking the state exam. They just got that email yesterday or the day before. There's a little bit of a lag between when they do their practical and when they actually are eligible for the New York State written, but that lag, they can start registering now. My other current class still holding on with 19. What else? Our 2 EMT classes going in the region. They're a little more than halfway done. They test in January. As far as what's on the horizon for the spring, we went a little bit different direction this spring. We're planning a CFR original and a refresher. We haven't done a CFR in a very long time. And we're planning that at Campbell Fire Department, which has been newly renovated and kind of has a new room and some new breakout rooms. And then here in Chemung County, we have just a refresher for both EMT and CFR going at Big Flats Fire Department. What's that? Oh yeah, I'll let Jim speak to his program too in just a second. We are not offering an EMT original in the spring. We didn't identify the need for it, just based on numbers and how much we've hit EMT pretty hard the last 2 years, even in the midst of the pandemic. But that's kind of what's in store for the EMS classes. But Jim has a really interesting program that I think is worthy of discussion.
Yeah, Mark's gonna have the Earn While You, we call it Earn While You Learn program. We're gonna be hiring full-time people who are just gonna go through EMT Monday through Friday, 9 to 5. And then when they complete the class, I think it starts in January, ends in April. I forgot how many weeks. It's 9 weeks, I think it is, 10 weeks. And then they'll be offered positions, positions when they complete that program. And we got we've had a very good response here. We're looking to try to put out 15 offers, and we I think we're up to 30 applications here at the moment already. Yeah, so it's getting a good response.
Now, that's based in Corning, or is that a Rochester program?
Well, we're gonna be teaching it down here,
Okay.
but our class,
The co-sponsor.
yeah, core sponsors and yeah, our CMR Syracuse. We're under their direction and under theirs.
So what is the EMT and then you give them a job? Is that what you said?
Yeah, well, they'll be employees as they're in the student status as a student. And then if they pass and complete the EMT program, then they'll be offered full-time EMT positions.
That's the way to do it. I guess you have trouble finding EMT.
They're not flowing in as they used to have been in the past. So we have to go out and find our own. And actually talking to our AMR Buffalo operation's been doing it for years. And they've actually found that the people they put through those programs are the people who tend to stay along this.
Yeah.
And those are the ones too that usually move on to paramedic and
Yeah, you build loyalty that way.
All right. Thanks for the update. We got a nice pipeline. Hopefully we get a couple to stay in the region, because I'm sure we could use them at your agencies. Anything, Mike? I haven't heard anything on QI. Any updates?
I've not heard anything. I think Terry had a meeting.
Yeah, she mentioned it at council meeting, but hopefully I'll get a chance. I'd like to sit down with Dr. Waslinski, Dr. Kellogg, and discuss some options for the upcoming year as well. There is some, obviously with all the changes in electronic PCR input and collection, certainly it's time for us to move ahead. And that was one of my goals for the regional medical director, was to help update our regional QA program. So now that Dr. Kellogg is on board, hopefully, if not before the holidays, right after the holidays, we can sit down and discuss what direction we really want to go in.
Consider it a date, Donnie. I'll get you. Onto the revision of the STREMAC policies. I think it's just more of the ones we've been assigned. We just got to sit down, make sure everyone takes a look at them and sends Mike an official, I've looked at them. They look okay, or I've looked at them. Please make these changes or updates. If you still have any questions about which one you've been assigned, please get in touch with Mike and we'll get you all set up. And we can get them reviewed, and hopefully by the next meeting, that might be optimistic, but hopefully by the next meeting that we can have everyone having reviewed their protocols. EPCR compliance, how are we doing, Mike?
I think right now we have a couple of holdouts. We were fortunate enough to have Peter Brody from the state pop down and make a visit to a couple agencies who felt they wanted to do something different than what the state wanted. And I think he's gotten them convinced that it's his way. So hopefully we should be closed out, except for the couple agencies that are MIA. They're like Burdette, is there one other, Bruce?
Game Mills, Burdette.
Game Mills is resistant, Burdette's MIA. I think that's, yeah. Other than that, everybody is pretty much coming along. So they acknowledge the big hammer.
Okay.
Hopefully by the end of the year, we'll have everybody except for the MIAs.
No. No, actually, it's one of your associates. That's two.
Mike, is there something that we can like kind of just send them a nice carefully worded thing, just reminding them about it? Or is it something that we should let the state know, or where are we at this point?
Well, I think that I think we talked about it a bit in the past, that it should come down to the medical directors can require them to do,
Yep.
and we're required to do a whole lot more than the state, because obviously they lose their medical direction.
Fair enough.
So if you all decide that's a pathway you want to get behind, that's a great thing. The state uses CME, which works nicely. But those last few holdouts that aren't CME, it might be worthwhile.
Well, aside from the CME recertifications, there, funding is at stake as well. The BLSFR agency loses its agency certification. They also lose New York State tuition reimbursement, which probably is more important to these two agencies than whether they do electronic PCRs or not. So maybe the approach is to remind them that all of the free CFR training and all of the free EMT training that they get will go away if they don't do this. Period. Their choice.
We've had those discussions with both organizations.
So sometimes you just gotta do it.
Yeah. Well, in about 30 days, that's gonna.
Fair enough.
I mean, as long as they've been given a warning and advance notice, they know what's coming. We can't force them to make a decision. We can try to give them the advice to make a good one, but ultimately it is their agency. They can choose, I guess, if they want to go down this road.
Correct.
They've had a year, but I think that's a good point that we should, if you put together a letter, that's a big bullet point. It's that plus the CME plus the medical directors, they lose medical direction. So, which hinges on their BLSFR anyway. And that's a great point.
Oh, but they only lose medical direction if their medical director chooses.
Correct.
And we know that many of the LSFR agencies use absent medical directors who sign on through American Red Cross or American Heart Association or
Who's got Game Mills?
private programs. Neither are ambulances, they're first response
I think that
agencies.
was.
Who,
He's very
who's
anti.
in charge of Game Mills, like, not wanting to do it?
Game
I don't know if we want to talk about that.
direction.
There's some within the organization.
I think there's an inner.
Maybe a discussion to be had offline.
Yeah,
This offline.
all right, well, in the sake of time and the sake of appropriate venue, we can move on to, looks like medical control certifications. I think most of the hospitals are taking care of medical control certifications themselves. I know Guthrie has reached out to Mike and I. We gave them the test that we have. Arnett on the onboarding, they have a medical control test that we give our residents, we give our attending physicians. So is there anything else on that we need to talk about, Mike?
It would probably be in our best interest if we get a list of who should have completed from each.
Okay,
And also, I think that Skylar, we still have nothing from Skylar.
gotcha. Are they giving medical direction to Skylar Ambulance or just other places?
Yeah, I believe the word we have from some of the BLSFRs is they attempt to contact Skylar. However, sometimes they bypass Skylar and reach out to Arnett.
I think that's happening more frequently because I've been seeing more Skylar crews, so.
Yes, so the rub there is, is the BLSFR going to get jammed up?
All right, Donnie, for the sake of moving that forward, you guys have more contact with Skylar medics through the STREMS Council than the true STREMAC. Is there any way we can reach out to them to find out what they're doing for medical control?
Yeah, we can. I guess my other question is, why would the BLSFR agencies feel at risk?
Delay in response. So they have some prolonged contact times.
Okay,
And they look for a little bit of direction.
okay.
I guess for that and transport decision, whatever they're using them for, we just need to know what agencies are using which facilities so we can ask the facilities for who's providing medical control. Okay, which brings us to the next topic of EMS and ED delay times. Donnie, how are you doing with delay times?
It doesn't seem to matter these days where you go. We're experiencing increased wait times. At my full-time job, I have crews waiting in excess of an hour to get offloaded. Earlier on, about a month ago, the suggestion was utilize the community hospitals because they weren't as over capacity. But we're finding that that's not the case anymore. A week or so ago, I got a call from a friend to the west to ask what our local situation was because every hospital from Jamestown to Cornell was either on delay or on diversion. They were out of places to take patients. It's not uncommon to walk into, and I'm sure I'm preaching to the choir, but not uncommon to walk into the emergency room and see half a dozen admitted patients in ER beds that have been there for a day or so trying to get a hospital bed. I talked to the Air Methods crew, the LifeNet crew out of Hornell the other night, and he mentioned that they're transporting lots and lots of patients from upstate hospitals to Westchester Medical Center.
City, daily.
In the city. And I personally know friends and family members who have patients who are transported to distant hospitals.
Philly's a big destination.
Just to get a bed.
Philly's.
I know Rochester declared a state of emergency yesterday morning over hospital accessibility, hospital staff. And maybe Jim's a little more attuned to that. I caught the backside of that.
But for our local facilities inside of the southern tier, so I guess that's Bath, Corning, Schuyler, and Arnett, are we getting reports of extremely prolonged wait times in the ER for crews to unload their patients?
I've not heard anything. I'm sorry.
Can we include that RPH in that conversation?
I couldn't hear you.
Can we include RPH in that conversation?
Yeah, I guess that's fair too.
Yeah, I mean, it's been bad everywhere though, right? Like Corning had 50 patients in its emergency department on both Monday and Tuesday. And we're not allowed to go on diversion even to try to decompress for a couple hours. So, you know, I feel bad. The comment you made though, Donnie, about the people or EMS agencies trying to use the community hospitals for better turnover times, I'll tell you what, that's hurting a lot of patients. You really ought to be taking the patients to the right place the first time, because we cannot move them anyplace. If once they're in your emergency department, especially at these outside, these like small little community hospitals, you try transferring them to the bigger centers, they say, hey, why don't you call back in 3 or 4 days? And people's are end up doing very poorly because of this. And I've had AMR crews tell me, Corning the past couple of days, not to pick on them, but they're like, hey, we just don't want to go down there. It's going to take too long. Well, I tell you what, you're doing the patient a major disservice when you do that. And it's been very frustrating to watch this happen and watch people decompensate because we can't get them to the place, you know, mostly due to EMTALA and some other issues. So it's not been good recently.
Dr. Berry, I'm sorry, I probably didn't explain myself as well as I should have. I certainly wasn't advocating taking patients to other than the most appropriate place. But where I work, we have a large population who is of the opinion that if they go to the biggest hospital in the region, they're going to be treated very specially. Even when their complaint is a very minor complaint that is very appropriate for the smaller facility. And some people honestly are scared to see a physician assistant in the ER. They want to go someplace where there's a doctor. So I'm certainly not advocating for dumping patients at the closest hospital because it's more convenient for us. I share your opinion. I think on getting patients to the most appropriate hospital for their condition. And utilizing all of our resources as appropriately as we can. I apologize, I wasn't clear about that.
Understood.
On the side of being an ER doctor, I can see that we're at extreme capacity at times. What Dr. Berry's talking about, it's not unheard of to have double-digit holders in each of our departments right now because there aren't beds upstairs. It's also very difficult because every facility we try to contact has the same situation. But for this thing, for the EMS and ED delay times, I just want to make sure that we're not experiencing extreme delay times, which would result in less crews available for 911 because our local facilities are taking in what's reported in the news sometimes is 1.5 to 3 hours for crews to leave the ER. And it doesn't sound like our region has reached that yet from what people are telling me.
So sidebar question today, Doctor. Let's say a small ambulance comes from, out in East Jesus and comes into the ER and you have similar acuity of patients. Do you prioritize the one who's got to get back to their little place versus I'll pick on Airways, versus an Airway guy sitting there and a Addison Woodhall, something sitting there? Do you prioritize, or is there a way to prioritize to get the small folks out the door?
I think then it would go for patient safety, just for triage. You would see which one needs the bed immediately and which one needs to get off the stretcher first. If you can't provide definitive care to the one, then even if the other smaller area needs to get back on the rig, if we have to stabilize the one patient first, then we have to stabilize that patient. So I think everything goes to triage, which eventually we're going to talk about ET3, which is more about appropriate triage and transport. But for right now, I think at Arnett, what I've seen is we try to get them off of the stretcher because our hallways are small due to construction. So if we leave an ambulance in a hallway, we lose even more space that way. I can't speak for the other facilities though. I don't know what their situation's like.
So a question for Dr. Berry also is how do we become aware of the condition at RPH if you're experiencing delays or some form of diversion or whatever? Because we get it from New York hospitals, but not RPH.
We got notified RPH about the diversion yesterday.
Did you? Who'd you get it through?
Some contact therapist, I trying to find out who.
I mean, we're just a conduit. When we get diversity, we push them out. But we don't get anything from New York State. We don't get anything from the RPH. And it might be valuable for us.
Because we haven't gotten word that they're no longer on diversion. This has been since yesterday.
Perhaps we could share with our PHR current diversion policy. Remember a few years ago, a couple of years ago, we revamped that diversion policy with great help from the Department of Health, which unfortunately, Dr. Berry, is probably why you're not allowed to go on diversion anymore. But we could certainly share that policy out with our PH and ask them to participate with notifications.
Okay. Well, we have Dr. Berry and Dr. Lincolnheil on here. They have good contacts with Guthrie, so especially their ERs, because they tend to be in leadership roles in the ER. So, well, let's move on to the next topic, the RSI revisit. This is a topic that Suffolk County just did a big study on. And it looks like in Suffolk County, with a much larger population than ours, there are between 50 and 80 cases each year. I still am not against RSI for credentialed providers if we have a robust plan in place and if we have the need for it. The only concern I have is the amount of work it'll take to develop all this, the sign off it'll take for all the medical directors. I want to make sure that it's worth the work that we're going to put in, that we actually have a need in the area to benefit this. Rick has found a few cases for it. If each agency finds that there is enough cases every year that would benefit from RSI, then I would be willing to take a look at it and see if we can bring it to the region. Now, my biggest feeling as an ER doctor is not knowing when to RSI somebody. It's to make sure I know when not to RSI somebody, because once you knock them down, you lose control of their airway, and you have to be sure you have other things in place. I don't know if others will echo the same feeling, but I want to make sure that the crews that we're training, if we end up going in that direction, know not when to do it, but also when not to do this.
So Rob, do you think it would be worthwhile to see if at the next STREMAC meeting, if Dr. Winslow would chat with everybody? If you're going to go down that road?
Dr. Winslow would do what? Chat?
You just kind of present on it.
Yeah.
We did a brief overview for the program agency directors, and I think he also did it for the REMAC or REMSCO, one of those. But he may sway people for or against, because he talks about exactly what you're talking about.
Yeah.
When not to, and also he talked about, you know, if things go south, get the knife. And I'm not sure people are prepared for that.
Yeah, I mean, if things go south, there has to be other ways to secure an airway. The crews have to be able to do other rescue maneuvers and potentially a surgical airway. I don't know how many surgical airways we've done in the last 5 years that we could even say that our crews are proficient enough to do it if we have to. So that's why if we decide that there's enough cases in the area and we want to proceed in that direction, it's going to be a whole lot of work and a whole lot of research before we even put a program in place.
Yeah. So to that, end, if you'd like me to try to get Dr. Winslow to speak for 5 or 10 minutes in the next one.
Yeah, that'd be great if he's able to, what was it, February 2nd was the next meeting, I think?
I believe so.
If he'd be willing to just talk to us and see what they did in Suffolk County to make it work. I know there's up in Monroe Livingston area, they put something in place, so maybe in the future we can hear from them too, if we're being swayed in one direction or the other. But it's something that myself, while I want to be progressive with it, also internally, I question, will people be cautious enough and know when not to use the skill as well?
An interesting tidbit I picked up from Dr. Cushman, who actually came on one of my calls not long ago. He noted that in the Monroe Livingston area, only 20% of RSI requests actually resulted in intubation. So 4 out of 5 of those requests wind up not being intubated in the field. So that's the number that they found to be appropriate utilization. So an interesting tidbit.
Well, that's my feelings on it. If we can get Dr. Winslow, it seems that anyone I've spoken to is also very divided on the matter. I would love to see it being available in case we need it, but if we don't stay proficient in it, letting somebody who's not proficient try to perform a skill is a detriment to patient care. So I want to make sure we're going to have enough cases and the proper backup before proceeding in that direction. And also our medical directors for the bigger agencies will have to be on board with it as well, because ultimately they're going to be responsible for the education and the maintenance. But that's all I have for old business. On the new business, we already heard from Peter. I don't see Ed, Don, or Brian. So we can go to the endorsements, Mike.
All of 5136s that have been in the pipeline are cleared. There was a few PAD updates. Those are just people refreshing their stuff. Harport Central School District, Armstrong Group of Companies, Chelsea Wilcox Auto Sales, Clemens Center, Corning Family YMCA, John G. Allman, Oral Surgeons, Southeast Bend Library System, Town of Southport. They just did updates. There was one new, that's Community Bank. Are they still in process or completed?
No, it's done for now.
Okay. BLSR FR updates, Golden Grove Fire Department, Cape Fire District number 1. And BLS ambulance updates, Fulton Volunteer Ambulance. They've all shuttled the paperwork to appropriate contact state.
All right, anything we have to act on? Everything look good?
I have a comment. I sent some paperwork in for the Clemens Center defibrillator to Karen Smith. Did you get that, Mike?
Yes,
Yes,
yes.
Okay.
they're done.
Okay, so that doesn't need any approval or anything. It's just a paperwork thing.
All done.
Okay, good. Thank you.
Thank you.
So then we have some updates on community paramedicine from the last CMAC, and a big thing that they're starting to push is the ET3, the triage, treat, and transport. And a big tenet of this is to allow patients that don't need to go to an emergency department either to be treated on scene or to be transported to an alternate facility. The people that this would include are right now, a lot of our agencies, if they do certain things like a diabetic wake up or a Narcan wake up and they sign the patient off, there's no reimbursement or anything like that. This would allow crews, if they file for it, to be able to bill for services rendered, not just transport. Another tenet of it was transport to appropriate facilities. Say if somebody think they sprained their ankle or a non-displaced ankle fracture, something that might not be surgical or emergent, they can opt to be transported to an urgent care or somewhere else that can manage the injury. I don't know how much in our area that would result in unloading of our ERs, because I think a large portion of the people would still prefer to go to the emergency department for various reasons. But it does present some promise for agencies right now that are performing services and not being able to reimburse for it, now being able to get reimbursed for services provided. For right now, the agencies have to apply, and I believe that AMR Corning so far is the only one that has filled out an application for ET3.
Yeah, we still have to find a partner, though. We've been trying to work with Guthrie, but at the moment, they're right now not interested.
Yeah, that seemed like a big portion of it too, is it seems like it would be most effective when paired with either an organization or a physician to aid with certain decisions or aid with certain treatment. And one of the other things that they were talking about, which was less than 50% enthusiasm for it, was instead of Narcan wake-ups, allowing patients who are in severe opioid withdrawal, rather than waiting until they go and get heroin, they go and get their next dose of whatever illicit drug they're using, that they could call and initiate buprenorphine or Suboxone in the field for them. So they are trying to move this in all different directions just to allow patients to get better access to treatment at home and not to need the emergency department as frequently. Any thoughts on our area of how we can kind of try to implement this a little bit?
Who in Guthrie were you?
We've been, it started off with Ted Cross, we had a meeting with Ted Cross, and we went up to the, we had a conference call with, I can't remember who was in that meeting, but then it went all the way up to, who's the CEO? What was her name? Yeah, Melissa, and she's saying right now that they don't see where the Guthrie clinics or urgent cares
Yeah.
can handle any offloading from the ED, so therefore they're not interested. And we're trying to relay to them and say, okay, we might not be able to do anything right now,
Right.
but if we can commit and show that we have a partnership somewhere in the next 4 years, we can.
Right, like long
Maybe do
term,
something.
like, because I'm wondering if like the primary care, like offices between, I have to say, like, our walk-in doesn't, like, has a very low threshold for what they will like kick back out and send people to the emergency room. Like 5-star will see a ton of stuff that our walk-in doesn't see. Or it used to be 5-star, I don't know what they call it now.
Well, now,
Yeah, well, now,
We have to have a partnership with someone and then we can move forward, but
yeah.
we are one of the agencies in this area that approved to do it.
Have you talked to Samadal's group, Southern Care, man?
No.
So he's opened up a few offices, one down by the Wesleyan Church, Dunkin' Donuts. True.
And we've
Very happy.
I mean, I even reached out when it looked like Guthrie wasn't going to be interested.
It seems
I reached out to Arnott. I talked to Beth Weir, who contacted some people from Arnott to see if they were interested in it, and then that died out as well. So I'm trying.
Yeah, it seems like Mark and we should be on board
That's kind of what I figured,
to
but
make this work, and I think it's worth. Yeah, I agree with you that it should.
yeah,
they
I don't want to
should-
lose
they
this
should-
opportunity and we're getting close to that.
They should do it because,
Because then it would take the weight off of the emergency room, which we're taking stuff in that we could,
right,
like primary care arguably could manage.
right.
Yeah, and it opens up the door too, like he was mentioning that, maybe we can also do the teledoc program.
Yeah.
And there's other thing, and Medicaid also just came on board. So now it's Medicare and Medicaid patients.
Yeah, I think.
So you mean like as you're at the patient's house, like you can telemed to a physician and, yeah, because we do that now anyway, so.
The big problem is without this, ambulances have no way to get reimbursed.
Right, no, yeah.
So
I
with
get
this
it,
program,
yeah,
we do.
Right.
Or we would.
So is there an issue with like the like Guthrie? Is it, so I hate to go to the billing bit, but is it like that they can't get reimbursed for this? Is that it? Is it like we're doing a volunteer? I mean.
If we take a patient to the urgent care center, they're going, I mean, that's.
Yeah, so that, I mean, it seems like
Yeah.
you'd still be able to bill if it's a billing issue.
Yeah, so that's
So
not,
that's
that's
not
not what
right.
she had expressed to us. She just expressed to us that she doesn't see where their urgent care, right now, in this current environment, the urgent
That's
care is
true.
not offload.
Like, I don't think the urgent, because the urgent care is swamped, but
I
the
agree.
primary care offices have openings. Between family practice, medicine,
Yeah,
so it'd be interesting to like see if there could be a collaboration between the primary care group, so that you only got really 3. It's Arnott, Guthrie, and Southern Tier. And if the 3 groups could say, hey, between the 3 of us, we can absorb this capacity.
I think they would, whatever agents, wherever they want to drop somebody off would have to apply to the state and be accepted as a receiving facility as well, to get a destination code and all the other. So it's got promise right now, but it certainly is in the early stages. It seems like it could help down the road. I see a lot of potential, but a lot of the questions that everyone's raising are the issues we're running into. It said on the early paperwork, physician. there need to be physician involvement, and I'm not sure if the urgent cares, which don't have a physician present in the area, will be able to most of the time. I don't know if they've changed the wording just yet.
Right, that's
but-
like, certainly all of us have physicians, and like,
Yeah.
plus, P and I do Suboxone. So if you, for the whole Narcan bit and outpatient, you know, starting Suboxone in the field, like those people are people who could come to us, we could start them. I mean,
So I think part of the problem right now is, honestly, for a system like this to work, it's gonna probably require a medical command oversight. Probably, you know, along the lines of an ambulance would call the ER, would call the regional medical command center, and present the patient, and then ask for permission to transport that patient to an alternative destination, or vet that decision to take a patient to an alternative destination. But my suspicion, as with everything else historically, like QA programs and all of that, this is such a small portion compared to everything else that hospital administrations are dealing with, that they just, if they don't look at it right now and just go away, they can continue to focus on the other problems. And that's,
probably the legal risk too. I'm sure they're worried that, you know, you're gonna drop something off at a primary care office that is.
Yeah, there's things built into the program. Again, this is all being looked at by Medicare and now Medicaid.
Yeah.
Yeah,
So Dr. Bear, are you still with us?
Yeah, I do have some experience with ET3. So the problem is a lot of the data has been coming back in that most of the urgent cares, they just, you know, turn these folks around. You know, I'm trying to remember the last time I really saw someone who came in by an ambulance. I was like, oh yeah, man, the urgent care could have taken this. It's actually a lot less than I feel like we feel it is maybe. But you do to get the ET3 contract, you have to be able to first have the urgent care to sign on. So even Hershey had a really hard time doing this because Hershey doesn't own urgent cares, and the local urgent cares didn't really want to play ball, and so they got the contract, but then the urgent care center was like, yeah, no thanks. And then the first couple papers that came out, that I've seen, at least I haven't paid a ton of attention to it, have been like, yeah, every time we bring, you know, the majority of the patients we bring to the urgent care, we feel urgent care appropriate, the urgent care ends up, you know, booting back to the ED anyways, and now we just have 2 transports, and maybe delaying care. So ET3, I want to be, you know, I want it to work, right? Like it would be awesome. Guthrie Clinic would be great, right? All of our facilities have a urgent care already in them, and so I would be like, oh yeah, that'd be awesome. We could just send them down to the ACT clinic and see if we can make it work. But you know, Guthrie has started doing some community, like MIH, community paramedicine, whatever you want to call it, with our heart failure patients. I have found these programs are a little more, have a little more value maybe when they're targeted to certain patient populations and keeping like high volume utilizers out of the hospital. But that's just been my experience so far. I don't know anyone who's like, oh yeah, we've really made this work yet.
Question, do you think there's an opportunity that some of the hospitals and urgent care centers don't understand the overall cost benefit or service benefit to the system? You know, it may not benefit me as a hospital,
Yeah.
but
I mean,
it could potentially benefit the system. I mean, even a treat in place, you know, a rig is out for an hour on call and gets a no load out of that. You know, that really doesn't help that part of the system. So I think, you know, I just wonder if maybe there needs to be a broad education piece to this and present too, so they understand the impact on the system. It's not just about me, the hospital. It's not just about me, the walk-in clinic. It's not just me about the ambulance, but together, you know, I kind of sort of think if, when they have these capacity issues.
And when it comes to these ET3, when it was first brought on to me, whatever, I at first was like, I didn't think it would be really well received here by, I think there was a big advantage. But when I learned more about this treating on the scene and then getting reimbursed for it, because I look at it right now, almost 50% of my calls for service or 911 responses result in a no transport. And if I can turn those around to those people can see a doc and then maybe, you know, I can get reimbursed as well or whatever, that's a neat part of the project, that program that,
So,
Yeah, I think there's definitely a place for the paramedics. Like, you know, you said 25% they don't transport.
What percentage of those roughly would you
So-
say are like addiction, narcotics?
well,
So if some of those get, you know, you know, the video conference with a doc, and, I mean, the paramedics certainly can make some decisions, but I mean, if they get at least to video conference, because most of the people don't want to come, and, you know, at least you get like some sort of direction towards their healthcare. You know, you gotta go see your doc, and maybe they can set that up, you know, get a, with your doc. I mean, there's a lot of things that, especially in the rural areas, those people are underserved, they're not going to see their docs. You know, and if this would bring them better care, because we're talking about better care, we're not talking about, you know, like pushing people away from the hospitals or pushing people into urgent cares when they want to go to the hospital. We're talking about getting better care for patients who, especially in our area where you get out to the rural areas and they're not getting any care at all. The government is pushing care to the big hospitals, and then you go out into the area, even around here where we have big hospitals, they don't come for the care for whatever reason. There's like many socioeconomic reasons. But, you know, this is a way to get, you know, them some care. Paramedics are certainly capable.
I mean, this may end up being that it just doesn't work or so or whatever, but that's what the purpose of this. It's a 5-year program. We're already 1 year into it, so it's 4 years left on it. But our problem that we're running up to as an agency is now we're up to near the deadline where we have to have a partnership. And without the partnership, we're now out of the program.
Right.
and the bigger, you know, the bigger picture, even beyond that, you know, diabetic weight dumps, we do a lot as an industry, diabetic weight dumps, and right now, agencies aren't allowed to get reimbursed for those. Because we've done what's right for the patient, they've gotten proper care. They've gotten what they need, and because they don't go to the hospital, and take up a bed in the ER to get another sandwich and get sent home, the ambulance, the agency gets punished. Field termination, cardiac arrest, it's non-reimbursable. That is a hugely expensive.
And how many hours on scene? Right, look at the work you just put in on a field term.
You just dump your ambulance or your drug box.
And you get zero.
And without
Zero.
ET3, if you don't transport that patient, you don't get reimbursed. So because you did your best job for the cardiac arrest patient, you treated them appropriately, you gave them everything that they would get in the ER, but because you didn't pick up and make that trip, you end up eating the cost.
Right. So then the doctor just says, oh, yeah, they're dead.
Exactly. You know,
That's what we do, you know?
So we're running into a lot of partnership issues, it sounds like, where one organization who, it sounds like most of the urgent cares are run by one organization where the other organizations don't have as much urgent care. It seems like WellNow, I think in our area, is responsible for a good portion of the urgent cares, and the other facilities don't seem to be all that willing to say, yeah, transport to someplace that I'm not
Well, I mean,
affiliated with, and the other places don't seem to want to jump on board with it just yet.
I mean, this goes back like 8 years ago when the WellNow or it was 5-Star opened up their first office in Big Flats. I said, you know, like someone said to me, you should do that. And I said, no, because Guthrie or Arnett is going to put me out of business if I do it. Well, Guthrie and Arnett did nothing. WellNow is like, I don't know, 100.
We're eating everybody's lunch.
Right, they're eating everybody's lunch. The ERs are losing money and patients. And, you know, so it's, you know, this is all like bad decisions from the beginning. And now I I don't think the hospitals are capable of making good decisions. I'm sorry, I don't have an affiliation with any hospital anymore, so I can say that. I'm not gonna get fired. It's just that they don't care about the community. They don't care about their patient. I mean, it's horrible. It's
I do agree. You made a bad decision not going into urgent care. It's fine. It's fine. But
horrible. Bad decision. Because I would have been Rich's John Radford, but you know, I don't have my island in the Caribbean.
well, come January, it's something that I could bring up at STREMAC of some of the obstacles that the rural portions of New York instead of the urban portions are running into. And also, I mean, some of our rural areas, Mark, that you were discussing, I don't even know if we'd be able to get internet out to those areas to do a teledoc or to do something else, to be honest with you. We have a hard time getting radio repeaters to go that far. So that might be another obstacle from what you're mentioning.
It'd just be a phone call. I mean, you know, doctors should be able to talk on the phone or, you know, but there are places that don't have cell phone in Chemung County.
Yep.
So this is County.
All right. Well, that was a topic that I expected to generate some heat, and it did. The other thing I wanted to talk about is just some research ideas. Donnie and I were talking briefly about, you know, the possibility of tracking the amount of Narcan wake-ups, the amount of drug overdoses, if they did implement something like the community buprenorphine. That's one idea that we had for a research idea. I know Dr. Berry is in the early stages of another research project. It's just something, if you see any potential for research, I don't want our area to stay stagnant and stay behind the times. If there's something that we could do to promote some educational discussion from our area, just please bring it up to the council. We'd love to hear about it.
Yeah, I think that, you know, like what Frank did for the ER there, he got a nice paper out of it, but he also, you know, did, I'm talking about the program where the ER gives them
Oh man, that was a lot of work. But yeah.
But it serves the community, you know,
Yeah.
I'm not saying, I think it's worth at least trying it in the areas, you know, with the people. I think, you know, a lot of times patients just wake up and they want to go home.
Can I was gonna ask you about this on the side, but, and I apologize because I gotta go because I got pieces of the for you, but, we were talking the other night, we did actually packaging of the burn victim course the other night, which was well done, pretty well. But we were talking about like all these patients who end up getting like hyper Narcan out in the field and are so awake that they are so happy and they don't need to seek any care. And whenever you remove the penalty of, or the downside of taking a lot of heroin and whatnot, then lots of times that just the behavior is reinforced, you know. So and so I was wondering if there's any interest in kind of looking into this kind of, not now, right? Because everything is so crazy, but maybe next year, like the strategy of like hyponarcaning people, you know, like narcaning enough to just keep them breathing and getting them into the system so that they actually get help. I know that seems a little like, you know, again, not at this point, right? Because at this point you want to keep everybody out of the medical system because it's so crowded. But like when we get to a point where there's opportunity to get these people into the healthcare system, if they are obtunded and you can keep them alive and then get them into a facility where they can get rehabbed, you know, otherwise they're just like, it's just this never ending cycle.
I think the issue was when I was in my paramedic class, they always taught just give them enough to keep them breathing and let them wake up over time in the ER. The thing that changed that seems to have been fentanyl. It always was with just diacetylmorphine or heroin. You could give just a little bit of Narcan and somebody would be breathing again. But the heroin being replaced with different types of fentanyl, I think has changed a lot of that for the ER. I am all for giving less Narcan than we give as long as the patient's breathing, because it'll let the person metabolize slower. And putting someone through opioid withdrawal, while in the vast majority does not kill them, it's still, your locus ceruleus goes crazy and you start releasing norepinephrine and your body goes through hell. You run a marathon by laying there. So if we could stop putting people into withdrawal, I would definitely support that. The downside is, I think the vast majority, and Brandon, Donnie, you guys can speak on it more than I can. The vast majority of Narcan is not given by our EMS. It's given by bystanders, by police, by the prison guards. And that's what I don't know how to target. If anyone has an idea on how to target that, I would be all ears and love to hear it.
So Rob, Dr. Helen and I were discussing this the other night, and you know, from MSTAR, we're a distributor of the Narcan. What we bump up against is actually it's coming from other Narcan suppliers. There's one that you may be affiliated with in this region who hands out Narcan willy-nilly.
Yep.
The law enforcement. Law enforcement is our biggest barrier to this being successful, because they run in and they bang them, boom, 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 boom. And, you know, then they're either walking away or there's somebody else's problem. You know, the problem with the reason all the law enforcement agencies went to that other distributor was because they didn't have to do education. So it's a process to slow down that flow of the free Narcan. And I'm not in any way encouraging not giving Narcan, but you know, they're not giving it the right way. You know, we preach, when we go, we give Narcan to any agency, we go out there and we hammer them. You know, we're not looking for a wake up. We want them alive, not woken up. Do not do that.
So there's a fear factor that's involved in that. If you've ever watched a police officer be the first on scene and they squirt that first dose of Narcan and the patient doesn't jump up and start dancing, they do the only thing that they know how to do, and that's keep squirting more.
Yeah.
So quite often you'll hear dispatch updates. It's like every 2 minutes, the patient's got another 4 milligram dose. Narcan's been deployed, Narcan's been deployed. It should be like an AED device where it'll only deliver a shock at certain intervals.
Yes.
But, or a PCA pump that's only gonna let you push a button.
Or, I mean, we can review more of them and see if they were done appropriately. But I've had plenty of times where someone gets upwards of 20 milligrams of Narcan before getting to the hospital.
Right.
Yeah, which is crazy.
But you know that law enforcement Narcan is off the grid. That's not counted. That's
Yeah.
That's the problem.
there's no
All right.
verification that they don't file a report with anybody. They just go get more Narcan.
The other thing I'd like to look into, and I would love to do like a study on this, like an intervention, would be like, I don't think that, my understanding is from like our first responders and our police and whatever, I don't think they're leaving any information with people, like resources, NA meetings, and I've been talking with, like, I've been kind of networking and Corning. Like there's the Two Rivers Church on Holy Street. These guys do amazing work with people who are in recovery. Like their meetings aren't like sit around a circle and talk about your past. They like take them out kayaking on the river. Do you know what I mean?
Cool.
Like, these guys like are really inspiring. They and I'm wondering if like we could do an intervention where very simple, where we just get a packet together of resources. And if you go Narcan somebody, you leave them with all of this information. Look, we just Narcan you. Call this number. You know, call this number tomorrow and just see, you know, if there's any increase in utilization of local resources.
I mean, the one thing I will say, just knowing both Arnett and working with Trinity in Dansville, if you give them Crisis's number, they can call their countywide crisis, and crisis is supposed to be able to set them up with somebody. But I agree that there's something that for people that have gotten Narcan, it's not just like a free pass. It wears off long before the drug, so you should be seeking help just to keep you alive and prevent morbidity down the road as well. But if you want to talk about it more, I mean, I would gladly talk to you about addiction medicine for hours. I mean, I just took my boards for it, so.
Oh, very cool.
But we'll move on to the next thing. You guys have some place to go. It was nice talking to you. Have a happy holidays.
Yeah, she has patience at 12.
Christmas.
Right, I'm sorry.
Alrighty. And then the last thing, Mike, you want to bring up the workforce study?
Yeah, I distributed it out there, but that's probably something that everybody just needs to flip through and be aware of. The workforce study was, I mean, neither one of these reports should be stunning to anybody. You know, those cases were baked long before they went in the oven. So it's just kind of an awareness thing and some discussions will likely be coming down the road. So information. I don't know if you want to touch on anything that.
My big feeling with them is it identified problems, but no segue into possible solutions. And there were problems that we already know about, and I don't know how we're going to address them. I would love to find a way. I'd love to look brilliant and say that there's ways we can fix this. That's why I was hoping that somebody, I mean, we could talk about it the next time after everyone's gotten a chance to read it to see if there's anything that we could think of. But the more I read into it, for Skylar, for Suben, for all the other stuff, it just seemed like there were, yeah, we see this happens, we know it. But now there's a paper saying that it's going on in front of us.
You know, Skylar's not unlike Steuben, except they're smaller.
Yeah.
And they're in deep denial. You know, you might say Steuben is in a little bit of denial, but Skylar's in deep denial.
I don't want the agencies to think it's like a defensive thing. It's like, we're saying these are deficiencies. We're not saying they're your fault. It's just that you have deficiencies, and to serve your public, to serve your people, this is what we have to address. But it seems like any one of these studies, as soon as they're published, it's like, well, this isn't our fault. This isn't our fault. It doesn't matter whose fault it is. We have to come to some solution of fixing it at this point.
You are correct.
But that's me jumping on a soapbox, which I don't want to be on top of. It'll crack under my weight. So we'll talk about it at another time, I guess, and leave this for an open forum for anybody else to discuss right now.
One last thing, Doc, from STREMAC in Semsco. On community paramedicine vaccination programs, Director Greenberg reported that out of 62 counties in New York, there are 41 counties with approved community paramedicine vaccination programs for both COVID and flu vaccinations. So I asked for an email with the status of our region. Chemung County does have an identified program with airway ambulance. Steuben and Schuyler do not. The department's goal is to have an agency, at least one agency in all 62 counties, Jim. And, I make that announcement here so that we can continue to work toward the director's goal with that. It's still a very simple, that's a much smaller undertaking than the ET3 project, but much.
No, it takes resources.
Just as, well, with ET3, they wouldn't be. So, and actually, Jim, with the COVID vaccinations, Medicare will reimburse you for doing the shots in the community. There is a vaccination administration fee schedule for that. So an agency can be reimbursed for doing the vaccinations. But either here or there, we can talk about those details offline, but I would like to see an agency in all 3 of our counties, at least one agency, doing the community paramedicine vaccinator program.
There is an unofficial way that some of the medical directors, we were talking afterwards, and it seems like the biggest obstacle in some of those smaller counties is staffing, where their objection is they're having enough trouble answering their minimum number of calls that they can't sacrifice the staff. I'm not saying that's what's going on with our places, but I know in the extreme north, that was some of the, where they're supposed to have 3 rigs, but they're running one of their rigs completely BLS because of a shortage of ALS providers. So it may be that we're reaching a similar obstacle here. I can't speak for AMR or Schuyler. I have no bearing on their operations whatsoever. But that may just be our obstacle, and I hope that it's not, because Brendan's trying to turn out some paramedics for us. So if it is, maybe he can help us fix that. Can you do a community paramedicine module just so that they start going in that direction, Brendan?
Oh, yeah. Yeah, we actually, we touch on it quite a bit.
But the vaccination training is available on and it's fairly quick and simple, and a simple approval process. That's my hope for the new
Yeah.
year. We can discuss that more,
Yeah.
but it was brought up by the director. And
I'm all for it. I signed off on a bunch of the airway paperwork for it, so, but if you're not, if they don't have someone affiliated with their agency that's willing to sign off on it, they might just need some help with that.
And secondly, Dr. Barry, if you're still there,
Yeah, I'm still here.
I read your paper. Congratulations.
Oh, thank you. Yeah, I know field termination kind of is one of those things that you know some systems don't do, but I think that it's you're probably not leaving a lot of people behind if you don't have ECMO, but thanks.
It's nice to see somebody published. It's kind of cool.
Yeah, we have a couple more in the pipeline, so but unfortunately I don't have a great database myself here, so I'm still doing most of my work through Geisinger, but it was actually on the other hand of that though, so it was pretty funny that got published, and so like cat's probably out of the bag. I will go and do CPR on people in horse if the fire department's dispatched. And the next day we had a CPR call, and we actually got the guy back. And the Ricky Skeeby from Horseheads turns around and said, "Hey, we read your paper. We knew we had to work him on scene, and we knew we had to get the heart started here and not in the ambulance." And well, hell, lo and behold, it worked. So I don't know how the guy did. He was like 38. I'm hoping he did okay. They shocked him a bunch of times, and I think he was blinking when they put him in the back of the rig. But you know, does work in practice.
There's been some good saves.
There's been some decent saves in the region.
I think it's-
Yeah.
All right. Well, if there's nothing else, then this is usually Dr. Sheriff's time to shine. Oh, you got something, Brendan?
Yeah, real quick, I'm sorry, I forgot. Next Wednesday, a week from today at 2 p.m. Via Zoom is my paramedic graduation.
Oh, yeah.
Yeah, I'll send it out to everybody here. Feel free to distribute it. It's via Zoom, so the capacity is not, not an issue.
Works
So,
for me.
yeah, obviously, if you're from an agency and you sponsored somebody, it'd be nice to kind of see some faces.
There's no in-person.
No in person.
No cake.
No cake, all via Zoom.
Okay,
I'm out.
All via Zoom. No.
okay, Rob. Before I make a motion, I just want to make a comment about the RSI, which has to
Yep.
do with, I think in order to do RSI, you have to have lots of practice. And in
Oh,
our
yeah.
area, the amount that you're exposed to is minimal. So I can't see people in the field being practiced unless they go in, once a month or what have you to the OR and practice with the anesthesiologist. I just don't see it happening. In my career, doing RSI, I can say I had to do a handful, but I, of course, have been in rural settings. So I'm pretty much against having it done in the field unless people are really practiced and expert, because there's no going back. Once they're paralyzed, they're paralyzed. So those are my comments. So, for you to go to great effort and paperwork to get things going when what we do in the field is probably extremely rare in need. There are going to be mistakes being made and people are going to die because of it. So anyway, with that comment, I make a motion to adjourn, and
Second.
everybody have a happy holiday. Oh, did we go through the future meetings for next month to approve that, or?
Yeah, Rob, did you want to adopt those dates?
Yeah, let's just go with those dates. I have no problem with them. We can just start adjusting our schedules now. February 4th, I think, was the next one you put, Mike, and you sent out actually just closed it.
Yes. February 2nd.
February 2nd.
February 2nd, yeah. And my internet just went down on my other computer. So Mike, can you read them off? Because my computer is not working.
They are February 2nd, May 4th, September 7th, and December 7th. And as it currently stands, those will likely not be hybrid. Those will be in person.
Okay. Anyone have any objections to those meeting days and times as of right now? All right, so we can set them as our meeting times for next year.
Very good.
All right. And then he motioned to adjourn. I will second that motion.
All in favor, aye.
Aye.
Yep.
Aye,
Everyone
aye,
have
aye.
a happy holidays and a happy new year. I'll see you in February.
Aye.